Hello everyone. Today I'll be talking to you regarding sickle cell anemia and G6PD deficiency. Both these topics are very important and asked throughout the world in all the exam. So I'll be discussing all these, but in addition to that, I'll be also telling you that I have launched a program called Smart Medicine. These are the recorded lecture of summary of Harrison what you need. These smart lectures are for those who really want to learn from Harrison, because ultimate book of medicine is Harrison, and Harrison has everything so-called integrated approach. I have made a summary of 300 hours plus of the recorded lecture are there, which I will be giving to you, all of you, free of cost, no charges. Detail I'll be talking to you at the end of the session. Okay, so let's begin with the this, right? So I'll be covering all the topic which are relevant to my talk, right, sir? So we have a question number one. We got a 28-year-old man, African American male. These are important. This is important, and this is also important. Why? I'll be talking to you soon. Prophylactic medication was given before he was traveling to Africa. Okay, he's an American person, but basically he's from Africa. Now he's again going back to Africa for a business trip. So when he came back, 4 days later he came back and he has jaundice and dark urine also. Lab shows anemia, reticulocytosis, and indirect hyperbilirubinemia. Peripheral smear shows RBC with dark inclusion when stained with crystal violet. What the pattern of inheritance? Lovely question is this. Okay, the answer of this question is X-linked recessive inheritance. But why? What is the problem with this thing? This patient has G6PD deficiency. Well, what are the points that are favoring at the moment is he is a 28-year male. We all know very well G6PD is an X-linked recessive disorder which occurs in males, and the female are the carrier. And African Americans, in fact, this G6PD deficiency is very common in Africa, in the Sahara belt, or the also called north of Africa. So he's going, of course, at the moment he's staying in USA and going to Africa. Of course, this can be anywhere. It can be London, it can be Paris also. Ultimate is he has to go, and he's going to Africa. And he's given certain prophylactic drug. We all know very well when people travel to this endemic area of malaria, that Africa is the endemic place for the malaria. He must have been given certain anti-malarial drug like chloroquine, etc., the prophylactic drug. And within 4 days, he got jaundice, he got anemia, reticulocytosis. Reticulocytosis means there is hemolytic anemia is there. I hope you are well aware that one of the classical feature of any hemolytic anemia is raised reticulocyte count. And the most important is dark inclusion body which are stained with crystal violet. What are these? This I'm going to discuss soon. As of now, the answer of this question is X-linked recessive disorder. Okay, so let's learn about this inheritance of this patient, right? So as we discussed just now, the patient has feature of all hemolytic anemias, and it is more in Africa, as I told you, G6PD deficiency, and they exhibit hemolysis that we have seen by reticulocytosis and indirect hyperbilirubinemia. Okay, so all the point which I discussed in the previous slide, I'm just re-emphasizing you so that you are very clear about it, that we are dealing with hemolytic anemia. And now come the most important line. This I'll spend time. Peripheral smear shows RBC with Heinz body. This is the characteristic feature of G6PD deficiency. They are dark intracellular inclusion that stain with crystal violet. So now you got an answer that why this patient is suffering from G6PD deficiency. Again, if you revisit the question, they also say that patient develop jaundice, and in the peripheral smear there is a dark intercellular inclusion body that's stained with crystal violet. But they did not mention the name. That means the examiner is very smart enough. He's talking about Heinz body. Or now golden line to remember. If you get Heinz body, you are dealing with G6PD deficiency. Very simple. Okay. They are the clue by which you can solve the question, or you can understand the Viva question, whatever is being asked to you in just 1 second is the Heinz body. Okay. Well, we all know that it's a X-linked recessive disorder. As I told you, female are the carrier and male are the sufferer. That's a classical thing. Okay. Now, in the option, in the answer, the other option were like mitochondrial inheritance. That is seen in which affect oxidative phosphorylation. Labor heredity optic neuropathy is the classical question. This question is very, very important. That mitochondrial disease, when they talk about 99%, they will be talking to you regarding Leber's heredity optic neuropathy. Okay, so don't forget. Regarding autosomal dominant, you know there are plenty of example. Autosomal recessive, plenty of example are there. That I don't think you I need to discuss about these simple things. Well, question number 2, a 30-year-old male, episodic jaundice, anemia, and he has been diagnosed as a case of G6PD deficiency, and now we know why he has got episodic anemia, jaundice. And his wife has a normal plasma G6PD. That means the patient himself is suffering and the wife is normal. Which of the following statement is correct? None of their children will be affected is the answer. Why this answer? Why not others? Let's learn the basics of genetics. So this is the genetics. We know very well that G6PD deficiency is a X-linked recessive disorder. So, well, let us say we got unaffected father and unaffected, the mother is a carrier. Okay, remember I am talking about a normal mother and the normal father. Clinically, of course, wife will always normal, but here the mother is a carrier. So we'll be getting, well, we have got X and Y chromosome and we have X chromosome. So we'll be getting unaffected male if Y, X, X, X. So this will be YX, this will be XX, this will be XX, and this will be the affected child. But this will happen only this scenario where the mother is carrier. Well, abnormal gene has been shown in the yellow color. So now the picture itself is clear. The scenario where the mother is carrier and the Y, son will suffer because the Y is combining with the X chromosome, which is a recessive disorder. Okay. But what a scenario. Now scenario is altogether different. This is Y, this is X, that is affected father. Mother is normal. Mother is normal. So what we are expecting, YX, YX, this is X, X, and this will be X and X. So we are getting two carrier, but none of the child will be suffering from any disease because this disease has to be manifested in the males. And these are the two sisters are there, but they are carrier. We got two brothers who are total normal. So point to be noted that in this scenario, things are altogether different. That's why the answer to this question is none of the children will be affected. Got it? So we are clear about. So I gave you two clinical scenario. One is the father is suffering, and other is the mother is a carrier. The things are different in both the scenarios. Now this is a lovely question. This is a ranked #1 question, and 99% students are not aware of this point. Lyonization is affected in X-linked recessive disorder. We go back to this scenario. This scenario, we got a girl child who got X and X. That I don't need to tell you that this is a carrier girl, but she is not suffering from this disease. We have been reading that it's always the male child who suffer, like this the scenario where we got Y and X. So we got the patient, and we have been taught from our first year of MBBS that it's in X-linked recessive disorder only males suffer, the female are the carrier. This is not an absolute true. Sometime like this scenario is there. This is the abnormal X and this normal. Suppose this X chromosome, this become inactive. This has become inactive, this one. This chromosome X has become inactive. That means now I can say inactive. This is single chromosome. Single other X chromosome is there, but it's not active. It is passive. So now we are left with only one X chromosome which is active, and this phenomena is known as lyonization. In this scenario, even this lady child will be manifesting any feature of X-linked recessive disorder like G6PD deficiency. Now, within a few minutes, you learn an extra thing. So far, before the class, you were only knowing that X-linked recessive disorder are manifested only in males and female are the carrier. But now, you learn an extra point that even the female child with X-linked recessive disorder can manifest due to a phenomena known as lyonization. So lyonization, one X chromosome become inactive, the other disease, the carrier X chromosome manifests, that can be there. Lyonization is there. Understood? So remember, write down the golden line to remember. Lyonization. X-linked recessive disorder. Female can manifest. Golden line to remember. The female can also manifest with this. Okay. Now we talk about question number 4. We are getting a 33-year-old African American male. Now I don't need to elaborate again on the word African American. With acute prostatitis, and he has been given trimethoprim sulfamethoxazole. That means he is getting sulfa drug. Dark color urine and high retic count. That again same thing. He has got a hemolytic anemia going on. Is a type of what type of hemolytic anemia? It is intravascular hemolytic anemia. Why this dark color urine is there? Write down the answer. Write down the answer. You get 20 seconds to write why in G6PD deficiency this gentleman is getting dark cola color urine. What is the basic pathophysiology behind that? Write down the answer quickly. Well, the answer to this question is because of intravascular hemolysis, there occur hemoglobinuria. So due to hemoglobin urea, there occurs, which occurs in intravascular hemolytic anemia, and that's why he getting dark or cola color of the urine. High retic count is a feature of all hemolytic anemia, whatever it may be. The normal retic count is up to 2.5%. Okay, this is normal retic count, and in this case, a retic count is always more than 2.5%. Right, and one more thing, retic count never increases in aplastic anemia. Retic count is never increased. So we learned something more about reticulocyte count also. So what's the most likely cause? Hereditary erythrocyte enzyme deficiency is nothing but G6PD deficiency. Okay. Well, this is hereditary erythrocyte enzyme deficiency. He has changed the word. In fact, he is talking about G6PD deficiency. It is hereditary, yes. It is an X-linked recessive disorder. It is an enzyme there in RBCs. And the name of the enzyme is G6PD deficiency. In fact, it is the most common type of hereditary erythrocyte enzyme deficiency. Okay. So, why? Now it is a sulfur drug. Sulfur drugs are again a very, very important precipitating factor about which I'll be talking soon. So when we talk about there are so many factors which can precipitate hemolysis in G6PD deficiency. The most important cause is infection. Then we have drugs, especially anti-malarial, sulfur drugs, etc. I'll be talking about these in the coming slide, but just to give you the basic outline, what are the important precipitating factors which can induce hemolytic anemia in a case of G6PD deficiency. I'll talk in detail in the coming slides. Question number 5. A 21-year-old man come to emergency department after noticing blood in his urine. He has been feeling fatigue and generally unwell for last 2 days, and he is having breathing difficulty. That he is turning yellow. That means he is getting jaundice. Okay. Well, now he is taking Primaquine, preparation for volunteering trip to Tanzania. Oh, Tanzania is a African country. So one thing is very clear, somebody visiting any African country, especially the North African country, like Tanzania, there's something to do, G6PD deficiency can be a problem. Well, he is jaundiced, tachypnic, dark color of urine is there, which is positive for blood and bilirubin also. He is afebrile, normotensive, and his HB is 11.5 gram per percent. MCV is fairly normal range. Platelet is normal range. WBC is normal range. Retic count is 2.1%. And we are getting schistocyte and spherocyte and bite cells are noticed. Most likely diagnosis of this is G6PD deficiencies there. Now, there are few things I like to highlight. Again, we go back. He is jaundiced, he has got dark color urine, he has got yellow also, and he was taking Primaquine, and after that the problem started. Okay. Well, if you look into this, we are getting schistocyte also, bite cells are being noticed. What are these bite cells? What are the schistocyte? We'll be talking in detail now. So regarding G6PD deficiency, it is very common in tropical Africa. One thing I've been talking to you, okay, it's a so-called northern part of Africa, so-called tropical Africa, is the most common location for G6PD deficiency. In addition to that, Middle East, Greece, Italy, and a part of Asia also. But in the exam, invariably they will talk into regarding any country of tropical Africa. Well, it is mainly intravascular hemolytic anemia. That's why we are getting dark color of urine in these patients. But one thing, again, not known to 99% student, there is some element of extravascular hemolytic anemia also. That means not every cell is broken down in the blood vessel itself. Many of these are broken down in the spleen and liver also. So this is a unique, G6PD deficiency is a unique phenomena. This is the top rank getting question. Any exam, maybe any viva, anywhere, maybe in the postgraduate level or MRCP level, whatever you talk about, this you don't forget. That one condition where we can have both intra and extravascular hemolytic anemia is G6PD deficiency. And these patients are protective against the Plasmodium falciparum. Malaria is again very frequently asked. Universal question is there. So friend, in this particular slide, this is important, and these are the 4 important keywords that you got to remember in this particular slide. Now we talk about why this happens. So far we have learned that whether patient is taking primaquine or trimethoprim or any sulfa drug that lead to hemolysis. That means so far whatever cases question we got it everywhere, a drug was there. So let's learn the basic biochemistry, why and how this happen. So for that we have to learn very basic biochemistry, okay, without which you will never understand. So we know, let's talk about glycolysis. We have glucose that is converted into glucose 6-phosphate and NADP. Now this NADP, this is converted into NADPH via G6PD. Okay, I'm talking about normal. Now this NADPH combined with glutathione, oxidized glutathione, and it is converted into NADH, and it is converted into glutathione. Okay, glutathione, which is a reduced form. Now this reduced form, we know very well in our body lots of free radicals are getting produced. One of the free radical is H2O2 also. Now this glutathione will convert H2O2 into glutathione oxidized and H2O. That means this is going to neutralize H2O2 and will convert into water. It means it is this glutathione which is the most important molecule, which will be converting H2O2 into water. So we need glutathione. Reduced form of glutathione is needed, and that is being given by what? It is the again oxidized glutathione will again come back, will combine with NADPH, and it will form a reduced form of glutathione. But we need NADPH. For that we need G6PD. If the G6PD deficiency will be there, so NADPH level will reduce, glutathione level will be reduced, and there will be no glutathione, reduced form of glutathione which can remove the free radical. Now these free radical H2O2 like molecule, they destroy the RBC membrane, and that lead to type of what? So-called intravascular hemolysis. This is the basic biochemistry. So in this keyword R, or the keyword to remember R is NADPH, G6PD, NADPH, and the reduced form of glutathione and H2O2. So they are the 4 keywords that you got to remember about the biochemistry of this process. Let's talk more about G6PD deficiency. We have two varieties. One is Mediterranean variety and other is the black variant. Let's read one by one, each one of them. Mediterranean variant, it is more severe. Well, in this patient, the half-life of G6PD is markedly reduced. That means they have less than 10% activities there. So that's why it is very severe form, because the G6PD activity is only 10%. And one more thing, something very interesting, the enzyme is highest in the young RBC. Any patient or any person, in the normal person also the G6PD level is very, very high in the young RBCs. But as the RBC they become older and older, the enzyme level start going down. Let me give you example. Whether it is G6PD patient or the normal person, the level of G6PD is really high. But in these patients, and with the age, it slightly goes down. But in these patients, this level goes down very fast. That's why younger patient may have little normal type of G6PD, but in the older one, the enzyme level is markedly reduced. So that's why a person takes any drug like sulfa or primaquine or a chloroquine, it tends to involve the old RBCs because they have very less amount of G6PD. So it is the older cells they are destroyed. Younger ones are still safe because they still have good amount of G6PD. What is the clinical applied of this particular statement? When we'll be investigating a case, we like to know the level of G6PD. What is the most important thing and very important exam question? It is said that suppose there is one patient who got episode of hemolysis today, then the G6PD level should be checked after 2 to 3 months. Why after 2 to 3 months? By the time the current new RBC will become old. We all know very well the normal RBC lifespan is about 120 days. So we want let this young RBC may become old, then after 3 months we like to check. But don't check G6PD level immediately after hemolysis. You are going to get a falsely higher value. A false why? Because you are not taken into consideration about the older RBCs. Okay. So now these patients, usually they suffer from chronic hemolytic anemia. And sometimes they may even have acute hemolysis also due to oxidative stress. Anything. Because oxidative stress will come, we don't have reduced glutathione with us. So this oxidative stress can very well damage the RBC membrane. Okay. And one more thing, these patients have protection against the Plasmodium falciparum. Well, extra knowledge for you. Not only this G6PD, which have a protection against the malaria, Plasmodium malaria, there are many other conditions also where they have protection against the Plasmodium falciparum. Thalassemia, known to most of you. Sickle cell anemia or sickle cell trait, which I just told you. G6PD deficiency and HLA-B53 also. So these are that means thalassemia, sickle cell, G6PD and HLA-B53. All these have a preventive protection against the malaria. This is a very, very important question. Don't forget this very important line. One more thing, that in this patient can have a severe acute hemolysis and chronic hemolysis. So it is this one which is usually intravascular. It is this one which is usually extravascular. Why is it so? This I'll be talking to you in the coming slides. Now we talk about the second variant is the black variant. The G6PD is moderately reduced 10 to 60%. Please note that this level was reduced less than 10% in the Mediterranean variant. So they have an episodic attack of again hemolysis once they are exposed to any oxidative stress. So now we have been talking about oxidative stress. What do you mean by oxidative stress? Let's learn the basic physiology, biochemistry and pathophysiology of the oxidative stress. What are the oxidative stress which are going to cause hemolysis? Number one, infection. Any infection is the most common cause. Most common cause is this. Okay. Well, now what happened? We all know very well the neutrophil and the monocyte. Monocyte are nothing but the other form of macrophage. Remember, monocyte in the blood is the monocyte, but same monocyte when it go to the tissue, we call it to be macrophage. And we also know they are the bacteria they are the one which kill the bacteria. So now what happened? They kill the bacteria, but they need oxygen dependent myeloperoxidase MPO. Okay, and this MPO requires NADPH as a cofactor. Now if NADPH is not there, they will not be able to kill the bacteria. I can give you a day-to-day example. Well, the neutrophil and the macrophage or monocyte, they are like a police, and they carry a gun. The name of gun is MPO, myeloperoxidase. The policeman is carrying the gun MPO, but gun is not sufficient. It need to have bullet also. Bullet are NADPH. And they are getting produced by G6PD. If the G6PD is not there, deficiency, NADPH will not be there. It means they are having the police having a gun without any bullet. A gun without bullet is of no use. It is just a showpiece. So that's why they are not able to kill the bacteria. Okay. So now, so infections are there. They are the one which can do oxidative stress. That's why infection are the most common cause of G6PD deficiency. Drugs also, again, they can produce large amount of free radical. Important drug are anti-malarial primaquine, dapsone, sulfa drug. Don't forget these three important drugs. List is huge, list is there. At least 50 drugs are given in the books. Do you need to remember? No way. No way. But you should not forget which are very, very important. That is the art of teaching to you. I always say, if you open the book like Harrison, has got 100 drugs. Whatever drug has causes hemolysis, the name is given in that book. But do we need to remember? No way. That is so-called smart medicine. What I have given you, what you need to remember, this thing. In addition, fava beans, don't forget, it's a universal question. Also, fava beans are a part of falafel, okay, or chicken peas. They contain fava. In addition to that, metabolic acidosis and red wine can also precipitate, but fava beans are very, very important. So let me show you what is fava beans. These are beans. And I'm sure you have been reading it, but perhaps most of us are not aware what the fava beans are. And they are the part of falafel. Falafel is a very, very important, delicious dish of the Mediterranean countries. And look, they contain these beans are there. They are a part of falafel. This is the falafel. Okay. Chicken peas. These are the chicken peas. Dried chicken peas. Very part of delicious chole bhature of northern India. The chickpeas we have been reading again. Oh, these are simple beans, so-called white chana in subcontinental country. So, well, any one of those who are very favorite of this dish, next time when you eat, oh, Dr. Bhatia mentioned about chickpeas, right? Right. So again, very delicious thing. Yeah. So we move further. So what are the clinical features that we talk? We learned that it can lead to acute hemolysis. It can lead to chronic hemolysis. Typically, black males who have been given, who have taken any drug which lead to intravascular hemolysis. The point I mentioned, no need to repeat again. Spleen size is normal. Again, a very, very important point. Unique thing. In fact, in all intravascular type of hemolysis, spleen size is normal. Of course, little bit of extravascular hemolysis can occur in this thing. Again, the only unique thing, only G6PD deficiency, the one which can have both intra and extravascular hemolytic anemia. So that's why by and large spleen size is normal, or maybe sometime if the extravascular hemolysis is a little more, little bit of spleen may be there. But by and large, for exam point of view, spleen size is normal. So the best initial test is always the peripheral blood film. In the peripheral blood film we get bite cells. Heinz body, which I told you this, if you get Heinz body, the golden line to remember, you are dealing with G6PD deficiency. They are by methyl blue or crystal violet, other color, the stain we use. Blister cells, they are the three classical question. Normocytic anemia and polychromasia, this is due to increased reticulocyte count. The polychromasia is a feature of any hemolytic anemia, but as of now, our main focus or talk is G6PD. These three things, if you get any one of them, 99% you are dealing with G6PD. Now let me show you what is G6 Heinz body. I've been talking to you regarding Heinz body. What are actually these? They are oxidized, denatured hemoglobin. Point to be noted, you got extra point, Heinz body, they are oxidized, denatured hemoglobin. Look into bite cell, okay? What happened? Suppose this is the RBC, and this is the Heinz body, this is normal RBC having Heinz body. They go to spleen, they tend to remove this, maybe they are able to remove only a part of the RBC membrane. So now the RBC become like this. So this part has been removed, so-called bite cell. Cannot afford to forget bite cell. Okay, bite cell, beautiful. Well, I think this is a better picture. Now you'll not forget. Any one of you who is using any Apple gadget, now next time you should, oh, this is the bite cell. Look into this. Bite cell is there. So now the bite cell are produced in the spleen, and many of the even RBCs are even removed or destroyed in the spleen also. That's why I've been telling you that some element of extravascular hemolysis does occur, and those RBC which get saved from the spleen, but they may get removed a part of the RBC membrane, and that's what they're going to produce, Heinz body. Blister cells are there. Some sort of blisters are there. You can see again due to same phenomena, the blister cell. So Heinz body, bite cell and blister cell, they are the classical feature. Okay. This surface blistering of the membrane. They may remove a part of the membrane. The rest two corner they come and join and they make a blister. The blister cell again seen in G6PD deficiency. Well, the most confirmative test is G6PD level. First we do qualitative tests. If need, we do quantitative tests. And I don't think I need to repeat that. You never do immediately after an episode of hemolytic anemia. It should be always done 2 to 3 months after the episode of hemolytic anemia. Is never done after acute. Normal level is 8.8 to 3.14 unit per gram of hemoglobin, but in these patients, G6PD level is reduced. But the most definite test is DNA testing is the most accurate test to diagnose G6PD deficiency. No specific treatment is there. It is all induced. So avoid oxidant, and especially those patients to whom you suspect either history is there or in that part, or the patient has come from that part of the world where G6PD deficiency is very common, and you plan to give it sulfur drug or maybe anti-malarial drug. Check the G6PD level before you give these drugs. Maintain once the attack is occurring, maintain hydration, give folic acid. That is true for all the sort of hemolytic anemias. Severe hemolysis, when the HB level goes down drastically, then you can give some sort of blood transfusion, and once you remove the stress due to whatever reason it may be, full recovery is the rule. Golden line to remember: a black African male come with sudden onset of intravascular hemolytic anemia that you know by dark color of the urine. After taking any drug, and you get Heinz body and bite cell in the peripheral blood film, this is G6PD deficiency. Friend, if you remember this line, whichever exam in the world you write, you will be getting your answer in these two lines. If you remember, the keywords are black, African, male, intravascular hemolytic anemia, drug, Heinz body, bite cell. So 1, 2, 3, 4, 5, 6, 7. There are only 7 keywords. If you remember this, you will be able to answer any question related to G6PD deficiency. I hope things are very clear to you. Little bit more golden line to remember. It is male. Golden line to remember: male patient, X-linked recessive disorder, African and Mediterranean descent in the ethnicity. Patient may even come with neonatal jaundice also sometime. Infection and drug precipitate and gallstone, that is a feature of any hemolysis, and gallstone will happen only in chronic cases. Chronic cases of hemolysis, Heinz body and major enzyme activity of G6PD, and again lovely summary of the whole gist is given in these 4-5 lines. Okay. Part 2 of the discussion. A couple who are expecting their first child, they come to you. Both are carrier of sickle cell trait, that is HBS. They want to know what are the chances the child will having sickle cell disease. The answer is 25%. Why is it so? Again, let's learn the genetics. We know very well that sickle cell is a autosomal recessive disorder. So autosomal recessive, we have a unaffected carrier mother. We have a unaffected carrier father also. So look into this. R, 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 R. If this R combines normal, one child will be 100% normal. Then R, 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 R. That means the two children will be unaffected, but they will be carrier. And finally R and R. And this will be the one who will be suffering from this. So out of the four, one will be totally normal. That is 25% will be totally normal, 25% will be having a disease, and the 50% will be carrier, although they are not suffering from the disease. Hence, the answer to this question is 25%. So let's learn more about sickle cell anemia. It's again a group of hereditary disorder, which I told you, autosomal recessive disorder. And they have a sickle cell in the blood. Okay, although they are recessive, autosomal recessive, but they have an incomplete dominance. Okay, what is the meaning of this? That's why even those who we call as carrier also may have some feature. Go back. So these two people who are the carrier, as per if you go by absolute value, they should not have any feature. But as I told you, although they are recessive, but they are incomplete dominance, some element of dominance is there. That's why even these two people, these children who are totally normal or but carrier, they may have some features. What can happen? This I'm going to discuss later on. So otherwise, what happens in these patients, the RBC, they become like sickle. What is sickle? Oh, this is the sickle. I don't need to tell you this, what is used to cut the grasses or some small trees or herbs, they are cut by this. So RBC, which are normally, which are like this circular disc, they assume the shape of a sickle like this. That's why they are known as sickle cell anemia. Okay, now, which of the following observation best describe the relationship between malaria and HBS is sickle cell. I don't think I need to repeat. These sickle cell are where Plasmodium falciparum malaria is endemic, and ethnic group they have migrated from these people. Oh, come on. He is not asking very smart question. So again, you'll be getting some new answer for that. What he did not ask that is more common in malaria. They are protected from malaria. That point we learned that sickle cell patient, they are protected from Plasmodium falciparum. But he has asked question in a different format. Okay, what the format, what the reason, I'll be discussing. Of course, we discuss sickle cell anemia is again very common in African Americans. So let me tell you what are the part of the world where sickle cell is very common. It is this part. Something, and this is so-called sub-Sahara countries. And Plasmodium falciparum is very common in this area. But why sickle cell is also common? Now come the question from genetics and evolution. Right from very beginning, Plasmodium falciparum, this is the hub of the Plasmodium falciparum, this part. So in evolution process, and we also know very well the Plasmodium falciparum, if not treated, it is a very deadly disease. It has got a lot of complication also. So in due course of time in evolution, they change. The HbA, which is normal hemoglobin A, it started developing into HbS, sickle cell. So this is so-called evolutionary protection. Don't forget this word, evolutionary protection. So evolution is a natural selection. We have know the basic biology, Darwin's theory of survival of fittest. So nature changed the hemoglobin so that at least the person can survive because of Plasmodium falciparum. So that's why because of so-called evolutionary protection, those people who are from sub-Sahara African country, if they migrate to any part, maybe Europe, maybe USA, maybe Australia, whichever part. So that's why they say when they migrate, or that's why say African American or African European or whatever you can say. The idea is to tell you the origin of the people is from the sub-Sahara Africa. I hope you understood the point what I mentioned to you. Question number 3 is 7-year African American males routine checkup. He run out of the breath and his abdominal pain, his bone also bony pains. Which changes we can occur? Protein changes. Oh, again they are talking about basic molecular biology and cell biology and as well as biochemistry also. Let's go into the basic. Valine substitution for glutamic acid is a very frequently asked question from the basic sciences. So we'll again the two questions I'll be discussing together. A 8-year-old African American male routine checkup and chest infections are common. He runs out, bones hurt. Okay, in fact, the same question is there. Sorry, typing error is there. Okay. So this patient is suffering from sickle cell anemia, and I told you is a type of hemoglobinopathy which occurs in African ancestry. So that's why we have been talking about African. And what happened in this patient? This is HBS. Let's learn the molecular biology. There's a point mutation at beta 6 position. In beta chain, in hemoglobin A 6 position, glutamate is replaced by valine. So what we write as glutamate valine. Okay, and chromosome involved is 11. And molecular biology change occurs we have got point mutation. The point mutation, what they call as non-conservative missense point mutation. You just got to remember point mutation. And this is single nucleotide polymorphism. Why single nucleotide? Only glutamate is getting replaced with valine. So that's why we call it single nucleotide polymorphism. So what you got to remember is point mutation, beta 6 valine. This is very, very important. Okay. Now, glutamate is hydrophilic. Valine is hydrophobic. Again, very, very important question from the basic science. We go back. This molecule, this is a hydrophilic. Hydrophilic means it is going to retain water. Valine is hydrophobic. It throws out the water. So now with this simple thing, this is the glutamate. It says water come in. And now this gentleman, he says water get out of the cell. Well, Now it is asking water to get out. The cell will be dehydrated. No need to say. So now it is dehydrated, it will change the shape to sickle cell. So that is the basic, very, very basic at the molecular biology. The problem is valine is a hydrophobic, and the original molecule glutamate was hydrophilic. So it lead to dehydrated RBCs. The mechanism I explained to you. Now in deoxygenated state, this hemoglobin S, it polymerizes. Polymerizes means it get precipitated. And once the HB get precipitated, the RBC shape changes and it becomes sickling. All right. So this is the basic molecular mechanism as well as genetic aspect, what changes occur. And sickling occur more in, again, deoxygenated state. This is very, very important point. Dehydration, very, very important point we learned. So it means what? The clinical applied will be, we never want he should be dehydrated. So we want him to be hydrated all the time. Anything dehydration will precipitate sickling. Moreover, we also know that in the deoxygenated state, it will be having sickling. We will never want him to be sickle. So we don't want him to, we always want him to be getting oxygen. The clinical applied is, we will ask him never to go to very great height or Himalayas or Alps. Why? We all know very well when you go to great height, in such places, oxygen content in the atmospheric air is very less. It is definitely going to precipitate. So they are not supposed to go to any places like this where marked hypoxia can occur. So the consequences of these sickling are hemolytic anemia or veno-occlusive crisis. This I have to explain to you. So this is the normal RBC and the RBC are like this. Sickle cell. Yeah, that's better. On this sickled RBC, they go to the reticuloendothelial system like spleen. They're abnormal. So they are taken away and they lead to a type of what? Extravascular hemolysis. So they have extravascular hemolysis by spleen. But the moment you hear this word spleen, and I'm sure almost everyone has a query in the mind, sir, there is no spleen in these patients. Yes, you are right, but you are half right, half wrong. What is half right? Spleen is there, and that's why they have extravascular hemolytic anemia. But this spleen is there up to the age of 9 to 11 years, around up to 10 years spleen is there. After that the spleen get autosplenectomy. The spleen get automatically, it get destroyed, it get fibrosed. But why? Let's learn. This is due to veno-occlusive crisis. What is this? Again, go back to basic concept. So we know that these abnormal shape RBC, they are getting removed, destroyed in the spleen or cell of the other organ or cells of the reticuloendothelial system. But these sickle cell, when they travel in the capillaries, they tend to adhere to each other like this. So they tend to block the flow of these blood because they have simply clogged. They have simply blocked these RBCs have blocked the blood vessels. So that lead to vaso-occlusive crisis. Due to same reason, they have repeated infarction. The spleen because the repeated infarction get autosplenectomy only after the age of 10 years. It's never at the age of 2 or 3 or 4 years, it's after 10 years. Point to be noted. It is this which lead to painful crisis. So this lead to painful crisis and this lead to chronic hemolytic anemia. So now we'll be having two problems. One is the pain, another is chronic hemolytic anemia. Okay. Now, very, very important point. At what age the child will have manifest? Usually, once the HbF is over, which is usually after 4, 5, 6 months. That means for the first 2, 3, 4, 5 months, the child will have no problem. Why? Because the child has HbF. And the problem is in the beta chain. Beta chain is in hemoglobin A. Hemoglobin F has alpha and gamma chains. Since they don't have any beta chain, that's why HbF is good for a patient of sickle cell anemia. And HbA become bad because the changes occur in these in the hemoglobin A. The clinical applied of this particular line, again repeating second time, HbF is good. So we'll be using hydroxyurea later on, which will having some effect on the HbF. So now we learned that at least one thing, the basic physiology, hemoglobin F is good. It is not affected in sickle cell because they have gamma chain. And one more thing, HbF has a higher affinity for oxygen. What he says, oxygen is mine. Oxygen is mine oxygen because it has got higher affinity. So the common thing is, that means if HbA is there or HbF is there, oxygen, it will attract toward more powerful. Simple, I got two magnet, small magnet, big magnet. A iron piece is there. Small magnet, big magnet, it will go toward way? Definitely this. Why? It's more powerful. It's more powerful is the magnet. So that's why same thing, oxygen, HbF has a more affinity for oxygen. Question number 5. 20-year African American hematuria, hemoglobin electrophoresis, HbA is 60% and HbS is 40%. 2. Well, if you look into this, one more thing, more I'll be talking little later on, but suppose there's one patient whom clinically you think maybe by history, by ethnicity, etc. you think is a case of sickle cell. You make a peripheral blood film, very easy. You can see the report only in 5 minutes. You make a film and you are getting some of the sickle cells. And if you really want to go for these, you have to go for hemoglobin electrophoresis. Okay, and of course in that you will get a peak of HbS also, hemoglobin electrophoresis. Most of us are aware that hemoglobin electrophoresis we do for thalassemia, but we do for sickle cell also. And now come the gold medal question. Write down the answer. I have a question for you. Lovely question, really good. When we are doing hemoglobin electrophoresis in a case of suspected sickle cell anemia, what is the single most important precaution you will take when we are doing hemoglobin electrophoresis in this patient? Write down the answer quickly in your copy. You get 20 seconds to think an answer. Okay, the answer to this question is you will do alkaline pH hemoglobin electrophoresis. The reason being acidic media itself precipitates sickling. So one of the most important thing in hemoglobin electrophoresis for sickle cell is alkaline pH hemoglobin electrophoresis. Well, as I told you, in these patients, they are the case of sickle cell trait, and the sickle cell trait and sickle cell anemia also both are preventive against Plasmodium falciparum. Okay. Well, in these patients, retic count is elevated. Quite possible you must have answered this also. In these patients, remember, it's not a case of sickle cell anemia, it's a case of sickle cell trait. Here, hemolysis is not a big problem. So this is out. Irreversible sickling is not a feature. This will happen only when this percentage is more than 50%, not a feature. Painful crisis is not a feature of sickle cell trait. MCHC is decreased. In this patient, MCHC remains normal. So this is the best answer. Okay. After that, we talk about question number 6. In sickle cell disease, which is correct, the RBCs of hemoglobin SC patient may sickle at when the PaO2 is low at 30 millimeter of mercury or 4 kPa. Well, in the last question I did talk about sickle cell trait, and I told very clearly that sickle cell trait patients are totally asymptomatic. But now, and in the very beginning also, I mentioned to you that sickle cell patient should not go to the great height like Alps, like Himalayas, where hypoxia is there in the environment, and that can precipitate. That was for sickle cell disease. Even for sickle cell trait also, if the patient go into great hypoxic condition, that can produce some sort of sickling can be produced. So that's why even sickle cell trait patients are advised not to go to extreme hypoxic condition. So let us learn more about these two types, homozygous, what we write as SS. This is actual sickle cell disease, sickle cell anemia. 1 in 500 in African American births, very high. Look, again, ethnicity is from Africa. And this is, of course, I'm writing African American, or this could be African European also, African anywhere. Of course, I have to write something, I'm writing African Americans. But this can be African European also, okay. Heterozygous are the one which are so-called sickle cell trait. Let's learn each one of them. So as I told you, sickling, symptomatic sickling occur in homozygous. Okay, heterozygous, of course, in deoxygenated state, that is very clear. Heterozygous are usually asymptomatic. Again, the point has been mentioned to you. So, and that's why heterozygous patients, they may just manifest with mild anemia that are often remain unnoticed. But one exception line, this you can't afford to forget. Exception in acute hypoxia like anesthesia or very high altitude where even veno-occlusive element can happen. It means sickling can happen. The golden line to remember, this is the golden line to remember. Sickle cell anemia are usually sickle cell trait. They are usually asymptomatic. But in any condition of hypoxia, maybe anesthesia, maybe great heights visit, they can develop sickling and they can have a including veno-occlusive phenomena also. We all know very well the basic concept about veno-occlusive is the sickle cell RBC. They tend to adhere to each other and they block the blood vessel. Well, nowadays, today news is there. Suez Canal, world famous canal in the Egypt. This canal, which lots many ship go and they save the entire trip of the Africa. Before this canal, the boats have to go around the whole Africa. Now in today's news is there, this is ship, big ship, it has gone like this. Total blocked by the ship. Now no ship can come, no ship can go like this. A huge loss to the whole world as far as economy is concerned, business is concerned, transport is concerned. Why? Only one ship due to this change position has blocked. It's a big ship. Exactly same thing happened in sickle vaso-occlusive crisis. Blood vessels, the RBCs, they tend to each other and they block the circulation. I hope you understood what I want to convey the message. Okay. So just to, of course, many of you are not familiar with the news. As I told you, Suez Canal, a big ship, has changed the direction. It is like this, and it has really stuck to the two corners of the canal, and that's why there is total blockage of the traffic flow. Now, what are the factors which influence sickling? Acidosis. The clinical applied is due to this reason only we use alkaline pH electrophoresis. Dehydration, the point I mentioned to you, these patients should be fully hydrated because valine is a hydrophobic molecule. Cold temperature again precipitate infection, hypoxia, anything, any hypoxic condition like anesthesia or great heights and fever, both can precipitate. Point to be noted, both cold and high grade fever, both are bad for these patients. Now, amount of HbAs is directly proportional to sickling. For sickling, 60% of the more than 60% of the RBC should have HbAs, but usually in hemoglobin sickle cell trait, this percentage is usually look in around 40% is there. So that's why in a normal sickle cell trait they have no manifestation except in extreme cases of dehydration or going to great heights, etc., where they may have sickling phenomena can happen. A 7-year-old patient brought to you and he had been already hospitalized many times for painful episode in the hand. For last several years, he takes no medication except for acetaminophen for pain control, and he has a valine for glutamic acid substitution at 6th position in beta chain. Oh, he's talking about molecular biology, and he's confirmed that you are dealing with sickle cell anemia, and his hemoglobin would like to get aggregate upon what he's asking. What are the factors which can precipitate sickling? He asked the question in a very indirect way. The answer is oxygen unloading. Okay, that means any AT2 hypoxia. Once they are it has removed, oxygen has gone away, unloaded. He has gone into deoxygenated hemoglobin, and that precipitate. Okay, that precipitate. Other things, they are not. The classical thing is he's talking about hypoxic condition. So, pathogenesis of sickle cell anemia. in the vein, low O2, so HBS polymerizes. Right? So it is due to the deoxygenated condition they cause sickling. Now sickle cells are very rigid. They are very rigid. They are not flexible. This need to be discussed. If this small capillary, a RBC come, in fact, if you look into the size of capillary is less than the size of the RBCs. Then how can RBC travel? Oh, fair enough. You happen to go to a cave. Cave is like this. Height of the cave is 4 feet. Your height is 5 feet 8 inches. And this is a 4 feet. So now you have to travel. What you do? You will definitely bend it. You will bend it or you will crawl because your body is flexible. Right? Suppose, so same thing with the RBC, which are very flexible, they fold and they can go by folding, twisting, changing the shape. But in contrast, if in case of sickle cell, the RBC become very rigid, it's not flexible. So now again the same Suez Canal story. Small RBC capillary size, big RBC, non-flexible. They will simply go and block the vessel, and that lead to so-called veno-occlusive crisis is there. Okay, so once the deoxygenated blood occurs, the oxygen dissociation curve shift to the right so that we want to release more and more oxygen. So curve is like this, oxygen dissociation curve, this normal curve. And in this cases, curve is shifted to right side. We all know very well that oxygen dissociation curve shift to right means more and more oxygen will be released, more and more deoxygenation, and that further lead to sickling. Deoxygenated blood is more sickling. So sickling causes now it lead to extravascular hemolysis. The point I mentioned is a very rigid RBC will be taken by the cells of reticuloendothelial system and then lead to extravascular hemolysis. And the very interesting, the RBC lifespan is only 17 days. Very, very important point. Normal RBC lifespan is 120 days. Now it is only 17 days, just around 15% is the lifespan. And it blocks the small vessel that lead to veno-occlusive crisis. I don't think I need to repeat it again. This is a classical sickle cells you can see. Cannot afford to forget this slide, sickle cells. Whole jolly body, again, this is very, very important. Cannot afford to forget this line. So whenever you are getting whole jolly body, either you are dealing with sickle cell or you are dealing with splenectomy. What is this? These are, look into this. They are small nuclear chromatin, small cytoplasmic red cell inclusion. They suggest hyposplenemia or high asplenemia whenever the spleen is not working. One more thing, I have discussed about vaso-occlusive disease, and I also talked to you that in sickle cell, autosplenectomy occurs. This is due to repeated infarction, the spleen get destroyed, but this occurs after 10 years of the age. Once the spleen is got destroyed, maybe due to any other reason also, spleen has been removed, like in hereditary spherocytosis, they tend to remove spleen. So after some time, you start getting whole jolly body. So in sickle cell, there is an autosplenectomy, this body will come. And now the question can be asked you to this way also. A child of 6 years with sickle cell anemia, which finding you will not see this. You will not see this in a child of 5, 4, 5, 6 years. This will develop only when the autosplenectomy has occurred. And after that also, after a few years, that means the right answer should be at what age you will see. At the age of, suppose the option are birth, 2 year, 4 years, 6 year, 10 year, 15 year. The answer should be 15 years. But this has to be, for that autosplenectomy must have been there. We also see gamma Gandhi bodies. They are small rust color. Cirrhotic nodule found in spleen in patients with sickle cell anemia, and they are also seen in portal hypertension. Okay, gamma Gandhi bodies, but in the exam point of view, this is the most important thing. So golden line to remember, HBS aggregates in the deoxygenated state. HBS makes polymers fibrous 10, and that reduces the flexibility of the RBCs. That means the RBC are very rigid. Sickling occurs in any condition with anoxia, low pH, that is acidic pH, and high 2,3 DPG. So these are the important conditions where sickling is precipitated. And as the RBC are non-flexible, they lead to microinfarction, they lead to vaso-occlusive phenomena. So the golden line to remember, that simply talk about what are the precipitating factor, what happened to RBC and why and how they are going to cause vaso-occlusive disease. Question 8. Most common feature is vaso-occlusive crisis is the most common manifestation. Okay. So as I told you, it's the most common manifestation. They lead to when the microcirculation get occluded, and that lead to ischemic injury of the organs supplied, and that lead to resultant pain. But this pain is very severe, very severe. It's such a severe pain that patient may be needing such a powerful drug like morphine. Simple non-steroidal anti-inflammatory drug, they are usually not very effective, but definitely the morphine is not so easily available in most of the countries. Of course, it has own, every country has their own laws, but one thing is very clear, it's not a very easily available drug. It's the most distinguished feature of sickle cell disease. SCD stands for sickle cell disease, and it now comes the gold line. It's the most common cause of leading crisis emergency department visit in a patient of sickle cell anemia or sickle cell disease. So the commonest presentation is, remember, patient has little anemia, he may have fatigue, he will not visit to you. But severe pain is there, he will 100% visit to you. Moreover, don't forget, pain is extremely severe, that the patient will be, usually they need a morphine or morphine equivalent derivative are needed to take care of the pain. Now you can imagine how severe the pain is. Question 9, we are getting a 9-year-old African American, high fever, chest pain, dyspnea, abdominal pain, which got resolved with analgesic and hydration. Retic count is 10%, hematocrit is only 21%, that means HB is somewhere around 7 gram %. And at autopsy, spleen is firm and brown, most likely rated 2. It's a 9-year-old child. Okay, he died. This is due to vascular occlusion. Okay, I mentioned to you that usually by the age of 9, 10, 11 years, patients start having autosplenectomy because of vaso-occlusive disease. Now look into this. He has got reticulocytosis, that means hemolytic anemia going on, and HB is 21%, HB level is very low, and patient has got fever, dyspnea. That means he may be having acute chest syndrome, about which I'll be talking to you a little later on. But spleen is firm and brown. This is due to vascular occlusion, which lead to fibrosed spleen. So-called autosplenectomy is there. Okay. Now in this patient, he has recurrent episode of abdominal pain. Yes, that got resolved on hydration and analgesic. Now I don't think I need to tell you why hydration is going to help it. So this is the case of sickle cell anemia. Now how he has come to you? He has come to you with fever, pain, chest, dyspnea, etc. This is so-called acute chest syndrome. Acute chest syndrome is one of the most important things that you should know. In a case of sickle cell anemia, is very, very important topic, which is nothing but a type of vaso-occlusive crisis localized in the pulmonary vascular circulation. Okay. So remember, now we are talking about vaso-occlusive disease of the lungs, which is manifesting as acute chest syndrome. So one more thing, it can lead to a patient of sickle cell disease, which is a homozygous, can also lead to splenic infarction, which is the reason why the patient has got autosplenectomy. Okay, so repeated episode can produce shrunken, discolored and fibrotic spleen, and that's why spleen is not palpable after the age of 9, 10, 11 years. The spleen may demonstrate brownish discoloration, hemosiderosis. Well, don't forget, we can get some gamma antibodies. There's nothing, same thing. And they have a type of extravascular hemolysis because they are abnormal shape, rigid shape RBC which are getting destroyed in the younger children, 4, 5, 6, 7 years, they by the spleen. Later on, it may be by cells, other cells of the reticuloendothelial system. Well, the other options, follicular hyperplasia and follicular hypertrophy, they are not the feature of sickle cell. There's nothing like pressure atrophy. Okay. There's nothing, no pressure on the spleen. Spleen get destroyed only due to autosplenectomy. It's the same question, same type of question. African American, 22-year age, and pains, HB is reduced, spleen is likely to have fibrosis and atrophy. Is the same continuation of the discussion what we made in the previous slide. The patient due to repeated infarction, the spleen get fibrosed and it get atrophied, and that's why spleen size is reduced. Question number 11. We are getting a 16-year-old girl, sickle cell disease, rapidly increasing dyspnea, HB is 5.1 gram %, so-called 51 gram per liter or 5.1 gram %. Retic count is 1%. What is most likely cause? HB is reduced and retic count is reduced. In the question they were typing error, it was, you can make it the correction. Retic count is 1%. There was some typing error in the question. Okay. So we are getting anemia with reduced reticulocyte count. Otherwise, sickle cell anemia is a type of hemolytic anemia. In all hemolytic anemia, retic count is increased. This is a classical feature of all hemolytic anemia. If retic count is not increased, then it's not a case of hemolytic anemia. But in our question, it's already a diagnosed case of sickle cell disease. but the retic count is only 1%. There is only one condition where this can happen is hemolytic crisis, that is aplastic crisis. And the commonest cause of aplastic crisis in the case of sickle cell anemia is parvovirus. Is also a cause of aplastic crisis in hereditary spherocytosis. HS stands for hereditary spherocytosis. Which of the following is of sickle cell disease need transfusion aplastic crisis? So then we got two questions which are related to aplastic crisis in a case of sickle cell anemia. So let's discuss in general what are the complications of a case of sickle cell anemia. Thrombosis infarction. Why vaso-occlusive disease? Simple. There can be certain crisis. There can be aplastic crisis. Classically, parvovirus infection. Don't forget, it's very, very important question. And this lead to aplastic crisis, and in this case, low reticulocyte count. So this is the only condition where the retic count will be reduced in sickle cell. Otherwise, retic count is always high in sickle cell. One more thing, parvovirus can also lead to pure red cell aplasia, can also be done. It may lead to pancytopenia. It can lead to even pure red cell aplasia can be there. Bone marrow infarction can also lead to pancytopenia. So even vaso-occlusive phenomena of the bone marrow can also lead to pancytopenia, but it's not a very common entity. So that's why in the exam, whenever they talk about aplastic crisis, think about parvovirus infection. Hemolytic crisis, suddenly RBC they start getting broken down, and in these cases retic count will be increased. That means to differentiate between hemolytic crisis and aplastic crisis is reticulocyte count. There is one more entity, so-called splenic sequestration. It occurs in infant and young adults. That means the whole RBC is pooled into the spleen. So definitely everything has gone to the spleen. So in the circulation, RBC count will go down drastically. It is again a medical emergency. It carries a very high mortality. It results in marked decrease in hemoglobin concentration, rapidly enlarging spleen. This needs some important discussion. Let's revisit. Which age group? Infant and young children. And we know at this age spleen is normal. Spleen get destroyed, atrophied at the age of 9, 10, 11 years. So we are getting 1-year-old child with sequestration of RBC. Suddenly the spleen will get enlarged. So we'll be getting splenomegaly. Remember, getting splenomegaly, sudden increase in spleen size can be a feature of sequestration syndrome. Hypovolemic shock can occur. Why? The whole blood has gone into the spleen. Here again we need urgent blood transfusion is needed. So urgent blood transfusion is needed in sequestration crisis. We also need in aplastic crisis. Here also we need blood transfusion. We need. Okay, the two conditions. Infection, bacterial sepsis is one of the greatest cause of morbidity and mortality. This is especially when splenic function are not there. And now, do I need to tell you that this problem occurs in the older children about 10 years? So, point to be noted, sequestration crisis with a splenomegaly occurs will occur in infant or very young children, 2, 3, 4 years. This infection, which is a very important cause of death also, it will happen only when the spleen is not there. That occurs after the age of 10 years. So especially these patients are prone to salmonella, osteomyelitis and pneumococcal infection. Okay, right? And the patient should receive prophylactic penicillin for at least 5 years of the age. We know occlusive crisis is a cause of morbidity. Okay, this lead to so the other word is painful crisis, which I mentioned to you. So-called hand-foot syndrome in children. They are more common in children or very young children. The symmetric swelling of the hand and feet are the infarct site. So this is so-called hand and foot syndrome also in children, very young children. Patient may have fever, pallor, and of course, very severe pain in the fingers. Now, sequence of events which happen in sickle cell anemia. Mild hemolytic anemia, they may appear by 10 to 12 weeks of the age. That means around 3 months. HbF is protective. That means the child will not have problem at birth. Problem will start occurring when the HbA start coming, and initially they tend to have hemolytic anemia. Splenomegaly after 6 months, but remember, because of extravascular hemolysis, the splenomegaly will happen, but autosplenectomy only after the age of 10 years. This point is not known to 99%. Point to be noted, child is born normal, no spleen, no problem. Child will start having problem at the age of 3, 4, 5, 6 months. Splenomegaly will start because of extravascular hemolysis, and after age of 9, 10 years, autosplenectomy will happen. The spleen size normal up to the age of 4 to 5 months. Splenomegaly, SM stands for splenomegaly, up to the age of 6 to 7 years. After that, atrophy. So sequence is like this. Vaso-occlusive crisis, maximum between 8 to 12 months, infant. Aplastic crisis, anytime after 6 months. This very, very important lines are there. Yes, you should remember. At what age hemolytic crisis occur, at what age vaso-occlusive crisis occur, and what age splenomegaly occurs. Okay. Sickle cell anemia is associated with granulocytosis or leukocytosis. Okay. So both total and segmental leukocyte number increase during vaso-occlusive crisis and infection. That is, there is leukocytosis occur. And in chronic cases, due to pulmonary vaso-occlusive, that means if the lungs are getting infarcted again and again, they can develop pulmonary arterial hypertension and so-called cor pulmonale. So remember, granulocytosis and pulmonary arterial hypertension. Don't forget these two lines. Heart can be enlarged because of hyperdynamic circulation. This is true for any anemia. Any chronic severe anemia will have a hyperdynamic circulation, which can lead to cardiomegaly. And reactive hyperplasia, bone marrow get hyperplasia, that is the feature of all hemolytic anemias. But in sickle cell in particular, it produces fish mouth vertebra. Very, very important question in radiology. Pathology also. We typically tend to get fish mouth vertebra. The commonest cause of death is sepsis in children, and in adults it can be acute chest syndrome. Well, as per NHLBI guidelines, blood transfusion should be given in following scenario. Acute chest syndrome, severe exacerbation of anemia with splenic or hepatic sequestration. I mentioned to you that if the sequestration anemia is there, crisis is there, give blood transfusion. multi-organ failure, patient having aplastic anemia, or patient prior to elective surgery, we can plan for blood transfusion. Question 13, which is the approximate pigment gallstone we can see in around 50% cases. In fact, pigment gallstone are seen in all cases of chronic hemolytic anemia, like sickle cell anemia, hereditary spherocytosis. And there are few extra things that we get in any cause of chronic hemolytic anemia, like leg ulcer. Leg ulcer and pigment gallstone are the two classical things that we see in conditions like sickle cell anemia and hereditary spherocytosis. And the gallstone, the percentage is as high as 50% cases this can be seen. So friend, in chronic cases, we get extravascular hemolytic anemia, HB in the range of 6 to 8 gram, reticulocytosis as high as 10 to 20%. Remember, the normal is less than 2.5%. Here it is almost 8 to 10 times more than retic. Cardiomegaly, why? Hyperdynamic circulation. Hepatomegaly is a site of reticuloendothelial system. Bone marrow hyperplasia, which is a feature of all chronic hemolytic anemia. Leg ulcer are seen in chronic hemolytic anemia. Jaundice because of hemolysis. There will be increased level of unconjugated bilirubin. UB stands for increased level of unconjugated bilirubin. Pigment gallstone, very, very important. Retinopathy because of vascular occlusion, and there can be increased viscosity because the RBC, they are not flexible, and that's why the movement of RBC is slow and they cause reduced viscosity. Hyposplenism or autosplenectomy, which occurs after the age of 10 years. Recurrent infection due to pneumococcal or hemophilus. This is a very, very important question. That's why we have given prophylaxis. Penicillin we have given because these patients are prone to these pneumococcal and hemophilus. Pulmonary arterial hypertension can occur and growth retardation can occur. Well, how often you have to do renal function tests in adult with sickle cell disease? Annual checkup. Let us learn about sickle cell nephropathy, very commonly asked question. It leads to recurrent UTI, and that can lead to chronic pyelonephritis, which can lead to chronic renal failure. Point to be noted here, the main cause of chronic renal failure is recurrent UTI. What else can happen in these patients? There can be renal papillary necrosis, and that lead to severe loin pain. Patient will come with severe pain in the loin. You can keep your hand over the loin, okay? And there is papillary necrosis is there, okay? Classically, if you examine the urine under microscope, routine microscopy you can get necrotic material. You get necrotic material in the urine if you see it. But most important question is, there is interstitial nephritis. Urine cannot concentrate, so-called isostenuria. This is the single most important because this entity, this can be seen in sickle cell trait also. The only finding which can be there in sickle cell trait is this, or sometimes they can have little bit of hematuria. These two findings you can see in sickle cell trait also. Okay. Of course, they can occur in sickle cell anemia also. So it is essential that annually the kidney function test should be checked in the patient of chronic sickle cell anemia. Well, sickle cell disease, which is true, they are unable to concentrate urine, the point I mentioned in the previous question also. Painful shoulder joint will respond to intra-articular steroid injection? No way. This pain is due to vaso-occlusive phenomena. It's not due to any inflammatory mechanism. Oral supplement iron are usually not required in any extravascular hemolytic anemia. They are needed in intravascular hemolytic anemia because in that hemoglobin urea occurring. So remember, in extravascular hemolytic anemia, iron therapy is not given. Symptom anemia are usually limited when hemoglobin equal to 8 gram. No way, it can happen any time. Spleen enlarged, no. Autosplenectomy is the feature, hence this the best out of this is the question done in excluding exclusive phenomena. We exclude all the possible causes, and finally we are left, and that we know the exact answer also. Even if you are not knowing, you exclude all the answer, finally we are left with this answer. Well, a brief word about sickle cell trait, we write as AS. Milder version of sickle cell disease and fewer crises also in those conditions where severe hypoxia is there. They usually have a normal blood parameter, normal MCV, no anemia, point to be noted, normal hematological picture. You can't even judge also the patient can have this problem. And the only thing is, they may have impaired renal concentration ability, and they present with isocyturia and hematuria. The point I mentioned, they are not able to concentrate the urine, and they may have a hematuria only. But it's a very mild, it's not very severe type of hematuria. UTI is very common in this patient. And severe hypoxia, which could be due to scuba diving, or those who are going to top Himalayas or Alps. So definitely neither they are supposed to go to top of the hills or Himalaya, and they are not supposed to go deep into ocean also. No scuba diving because they can lead to thrombus formation, especially splenic vein thrombosis is common in scuba diving. Visual disturbance because of retinal function disturbance. Okay, now remember this will happen only in severe hypoxia. As such, in sickle cell trait, painful crisis is not a feature. No specific treatment is needed because there is no problem, and they are also protective against the Plasmodium falciparum infection. Question 16. What is the mechanism of action of hydroxycarbamide in the setting of use in sickle cell? First of all, let me clarify. This is the other name of hydroxyurea. So different names are given in different books, okay? Especially when you talk about hydroxyurea, it stimulates production of fetal hemoglobin, the point I mentioned earlier also. And we know the basic concept that HbF has a alpha and gamma chain, and in sickle cell the problem occurs in the beta chain. So as HbF will be produced more and more, and that will remove all the feature of sickle cell anemia. So hydroxyurea, also known as hydroxycarbamide, it is an anti-sickling agent because it tends to produce HbF to 14 to 15%. Let me tell you, normal value is less than 1%. Now 15% HbF, wonderful. So as HbF it will be increasing, so HbA will be reduced. So that will reduce the vaso-occlusive crisis, will reduce the pain of acute pain. We know very well is a vaso-occlusive crisis which causes acute pain. So definitely pain is less, reduced hospitalization, prolonged survival. But not everything is safe. It's a teratogenic. So no need to say it is absolutely contraindicated in pregnancy. And moreover, it does not prove effective. Then the chronic blood transfusion are also given. There is other one more way. But when we are, of course, the second way of treatment is chronic blood transfusion. But chronic blood transfusion also have their own problem. So it means we have to go by balanced way of chronic blood transfusion or hydroxyurea. But as far as exam question is concerned, hydroxyurea is we use in this condition. It causes increase in HbF concentration. Now I have a question for all of you. Write down the answer in your copy. The question is, tell me hydroxyurea is important in which type of blood malignancy? Quickly write down. In which type of blood malignancy we use hydroxyurea? Well, the answer is myeloproliferative disorder, especially like polycythemia vera and essential thrombocytosis. MPD is the myeloproliferative disorder. PCV is polycythemia vera. And ET is essential thrombocytosis. I have taken the full test and discussion on these topics also. And all these topics are there in YouTube. You must go and see all the previous tests and discussion if you have not seen any one of them. Finally, the only definite therapy for sickle cell is bone marrow transplantation. Okay. The golden line to remember, extravascular hemolytic anemia with ischemic episode with autosplenectomy is sickle cell anemia. Any black person with unexplained hematuria, do screening for sickle cell anemia. So I hope you learned a lot. Next test and discussion will be on Saturday, 3rd April, 2 p.m. India time. The topic will be thalassemia and hereditary spherocytosis. I have already done these tests and discussion. All these, they are in the YouTube. Must go and see these. Well, I have very, very important announcement for you. I have done the recorded lectures are there, and they are in the name of Smart Medicine. They are the recorded lecture of Minnie Harrison. If somebody asks me which is the best book to read medicine, beyond doubt, Harrison the best book, no doubt about it, is the ultimate book to read in the integrated way, where you want everything should be discussed at one place. That is the need of every exam in the world. There's no everything is same, but it is too vast, like Gray's Anatomy, Goodman and Gilman in pharmacology. They are too vast. Am I right? One of your junior asked you, the one who got just admission in MBBS right now, I want to read anatomy. Should I read Gray's? What you will say? No, don't read Gray's. You read some basic book. Then Gray should be used as a reference book. Reference book means you have studied something, you want to know something extra, you go and see that point only. Same thing with Goodman and Gilman also. You read any book of pharmacology, basic book. For any more detail you want to go, then only read. So they are reference book. The difference between textbook and the reference book. Textbook are what you read. Reference book is which you consult occasionally. Same with Harrison also. You need 30 minutes to read one page of Harrison. You need 2 hours to understand. But you forget that page only in 2 minutes only. So that's why Harrison is not a textbook. Even at the level of post-graduation also, it's not a textbook. First read the basic. Basic is too vast. It's an ocean. You are not going to drink whole water of the ocean. So I have solved your problem. I've recorded the lecture of entire internal medicine based on 20th edition of Harrison. Okay, there are 300 plus hours of lecture. If you know this much, you can walk through any exam in the world, any exam. Basic concept, everything I started from basic. That means any topic like thyroid, I start with the embryology, anatomy, physiology, biochemistry, pharmacology. In HIV, I could discuss everything, A to Z. Everything is A to Z. If you read that topic, your basics are very, very strong. Majority of things I have covered up. If you need little bit extra, then only you need to open Harrison. In fact, I have done in such a way that even you don't need to read open Harrison also. Okay. Well, first of all, people do say how to contact you. You can very well contact me on my Telegram group, Dr. Bhatia T&D series Telegram group is there. You can ask any question to me. I'll be too happy to answer your question. But the good news is that Smart Medicine, which is their online lecture, you can use them free of cost for a limited period, of course. Good. You can use. You fill the Google form. Link is given in the Telegram group also. The link is given in your test paper also. What you have done today, link is there. You fill that Google form. That Google form will go to my staff, and once they have all your, and they will give you the access to the video lecture. You see, enjoy, and you will find they are the best lecture in the world. You will imagine how much hard work I have done to make. I have spent 15,000 hours to make this lecture of 300 plus hours. Imagine how much work hard I have done it, and it's totally free of cost. So you can assess. If you have any problem in download or anything else, you can very well contact my staff. You can WhatsApp. Don't call them, you WhatsApp, because so many calls will be create problem for them. So calls will not receive. You WhatsApp me because we'll be expecting a lot of calls. So WhatsApp we will take care of, we'll reply each one of you. We like to give you the access very fast, but since today is Saturday, tomorrow Sunday is off, and day after tomorrow again there's a festival in India. But still we like to give you the access today only, or maybe tomorrow also. My staff will be working tomorrow also to help you out. So take the advantage, tell your friends, colleagues, it's free for everyone. If you want to see the Smart Medicine, the best medicine lecture in the world, mini Harrison lecture, free of cost, join it. This very popular book, Mini Harrison, I have written is okay. The recorded lecture are of course definitely better. Why? Reading and listening, you always understand better on listening rather than reading. So recorded lectures are there for you. Take the advantage, no charges. I want you to become from a star. I want to make to moon. There are millions of stars, but there is only one moon. So I want you to become a topper, champion. Every exam you come with the flying colors. Remember, champions are not born, they are made. Okay, you get good trainer. You get good person who can train you. Remember the other way around, Arjuna are not born, they are made. This country or this world doesn't lack in the people who want to become Arjuna. They don't get Dronacharya. So here is the one person who is there to guide you, to make you the champion. See and then decide, and do let me know how do you like the lectures. You will find they are amazing lecture. I'll be waiting for your messages. You can very well note down my email ID also. It's easy, dr.bhatia at the rate dbmi.edu.in. It is DBMI. It's not DBMCI, it's DBMI. So Dr. Dr.Bhatia at the rate of dbmi.edu.in. If you have anything to ask me, I'm there to help you out. Okay? Right? I hope you have written it. drbhatia at the rate dbmi.edu.in. Thank you very much. God bless all of you.